Okay, thank you so much for listening to this talk. It'll be short, I promise. You know, a couple of years ago, when I was a third-year radiology resident, I decided to become a breast imager. And that was actually a very difficult decision for me because there was a lot about radiology that I actually liked. But in the end, I thought breast imaging was the best fit for a number of reasons. I remember it very clearly. I was on my MSK rotation. And then a couple of days after I made that decision, I opened up the New York Times to read this. Vast study casts doubt on the value of mammograms. Here's a quote from the article. One of the largest and most meticulous studies of mammography ever done, involving 90,000 women and lasting a quarter of a century, has added powerful new doubts about the value of the screening test for women of any age. And I was crestfallen. I really was. I was convinced that I would be, I'd made the wrong choice by going into breast imaging. I would be out of a job in 5 years. And I was bummed for a while. And then at some point, I decided, well, let's wait a minute here. Before I let the New York Times seal my fate, why don't I look into the literature for or against screening mammography for myself? And so I did that. And that journey, it really culminated in this talk. And it's something that I continue to do to this day. So if there's an overarching theme to my talk, it is this. Screening mammograms save lives. Okay, I believe every day when I get up and go to work and interpret screening mammograms, I am saving women's lives. And I believe that if you out there interpret screening mammograms, you too are saving women's lives. And even if you don't interpret them yourself, if you recommend them to your loved ones and your patients, I believe you too are saving lives. So my talk is divided into 4 parts. The first is called Screening Mammograms Save Lives, even for women 40 to 49. I will show you a lot of data to support screening mammography. Second part of my talk is called Good, Not Great, where we look at how radiologists in the real world are performing. The third part of my talk is tomosynthesis. It'll be very brief. Dr. Sullivan did a great job. I'm just going to highlight a couple of things that weren't yet mentioned. And then the last part of my talk is called critical scrutiny. I'll explain what that means at the end. So first part of my talk, screening mammograms saves lives, even for women 40 to 49. So this is the study that the New York Times was referencing when it said, vast study casts doubt on the value of mammograms. It was published in BMJ in 2014. And the one thing I want to mention in the title is that this is known as the Canadian National Breast Screening Study. And that's important, and you'll see why later. But this is a huge, this is a randomized controlled trial, and it's in a good journal. So how can I possibly convince you, now that we know this study exists, that screening mammograms do indeed save lives? Well, fortunately, I have some help, and his name is Dr. Smith. And he is a powerful ally to have if you're recommending screening mammograms for several reasons. First of all, he is not a radiologist. And in fact, he's not even an MD. He's a PhD. So that makes him much more objective than, say, me. He has spent his career studying cancer, not just breast cancer, but all types of cancer as an epidemiologist. And he holds an important position in the most powerful cancer organization in the country. So when he talks about breast cancer, we should listen. And fortunately, he has written extensively on this topic. Way back in 2004, he published this article, which basically summarized the findings of the major randomized controlled trials involving breast cancer screening. The trials are listed here, and there's 8 of them. And you can see right away, most of them took place a really long time ago. But what's really unprecedented, at least in my mind, is that we have 8 of them. I mean, these are really expensive studies to do. They're very labor intensive. And to have 8 of them is fantastic. Now, this is the most important table in my talk. And if you remember nothing else, I want you to remember this. So this table describes the overall results for breast cancer mortality. And it's listed as a relative risk, which means a woman's relative risk of dying of breast cancer if you screen her regularly. And a number less than 1 means there's a survival benefit, and a number greater than 1 means you're actually more likely to die of breast cancer. And the overall result at the bottom is 0.8. So that translates to, if you screen a woman regularly with mammograms, you reduce her risk of dying of breast cancer by 20%. That's really good. It's comparable to colon cancer screening, it's comparable to cervical cancer screening, both of which are much less controversial. But I'm going to expand this table a little bit. So you've already seen the first 2/3 of this table, but now I've added something, relative risk of being diagnosed with node-positive disease. And now let's look a little bit closer at the individual trials themselves. And if you look closely, you'll find that 2 of them are outliers. They're outliers because they're the only 2, and it's NBSS1 and NBSS2. They're the only ones where the relative risk for mortality hovers around 1, so they didn't show a benefit. And in fact, women in this trial, in these 2 trials actually, were slightly more likely to be diagnosed with node-positive breast cancer. So what the heck is NBSS1 and NBSS2? Well, collectively they're known as the Canadian study, the very one that the New York Times was reporting on. So I think it's a little bit misleading to say that this is late-breaking news, a recent headline, because we've actually known for a very long time that these were the only 2 trials that didn't show a benefit. But let's take things one step further. Why would it be that women in these 2 trials were more likely to be diagnosed with advanced stage breast cancer? Like, that just doesn't make any sense until you look at the details of these 2 trials. Interestingly, women in these trials, before they were enrolled in a particular screening arm, or a particular arm, either screening or no screening, underwent a very thorough breast exam by a nurse. And if that nurse felt a lump, those patients were automatically put into the screening mammogram arm of the trial. Now, in my mind, the trial is no longer randomized because you're taking women with a lump who are statistically more likely to have breast cancer, and you're putting them in the screening arm of the trial. And so it makes perfect sense then that women in these trials were more likely to be diagnosed with node-positive disease. So in my mind, this completely negates the findings of both of these studies. Of course, this wasn't mentioned in the New York Times. But even if you don't believe me, if you think I'm spouting conspiracy theories, which maybe I am, you have a preponderance of data, 6 out of the 8 randomized controlled trials showing a benefit. So as many randomized controlled trials as there have been involving screening mammography, we actually have more meta-analyses. And Dr. Smith and his colleagues summarized the findings of the meta-analyses very nicely in this article, and I think this is a fabulous article, highly recommended reading for everyone. So here's a summary, a distillation of the findings of the major meta-analyses, and you can see that all of them show a mortality reduction, from a low of about 14% all the way up to 48%. So hopefully I've shown you a lot of data that screening mammograms do in fact save lives. But when we're talking about a screening test, there's one little detail that we have to mention, and that's the number needed to screen. The number needed to screen to save 1 life. Because you can imagine, no matter how good your test is, if you have to screen 80,000 women to see a benefit, it's simply not going to be cost effective. Fortunately, all of the major meta-analyses publish this number, and they're listed here. Now, these numbers really vary. I mean, they're all over the place, from a low of about 111 in the Euroscreen all the way up to 2,000. Why should these numbers vary so much? Well, Dr. Smith and his colleagues looked into this, and in order to do so, they identified one of these meta-analyses that they believed stood out above all of the others. And it was this one, the UK Independent Review. It was published in The Lancet in 2012, and they liked this meta-analysis in particular for a couple of reasons. First, it was formed by a panel with substantial expertise in epidemiology and breast cancer management, and no panel member had previously published on this topic. They also really liked the details of this review. So in the UK Independent Review, they specifically looked at the number needed to screen, not the number needed to invite. And intuitively, you can sort of imagine why that's important. If you invite 3,000 women to undergo a screening test and only 100 show up, but you're going to use that 3,000 number to evaluate the test. Are you really evaluating the test, or are you evaluating your ability to be persuasive to get these people to come, or how good your directions were to the imaging center? So it makes sense, number needed to screen. It assumed a screening period of 20 years and a follow-up of 25 years. And this is important. When you're talking about cancer, you need long follow-up. It also focused on women 50 to 79, and you'll see why in a minute that's important. But if you factor all these things in, you get a number needed to screen of 180. Now let's contrast the Nordic Cochrane review with the UK independent review. Now the Nordic Cochrane review looked at number needed to invite. It also assumed a screening period of only 10 years and a follow-up of only 10 years. And by their own admission, they focused on trials dominated by younger women. And so when these factors are at play, you get a number needed to screen of 2,000. So Dr. Smith and his colleagues took things one step further, and they said, what if we decided to take all of the meta-analyses and we made them fit the UK model? So we assumed number needed to screen, not invite. We assumed 20-year screening period, follow-up of 25 years, and focus on women 50 and above. Well, if you do that, then all of a sudden, the number needed to screen between the different meta-analyses are much closer. And the number I want you to remember is about 200. So for women 50 and above, you only need to screen about 200 women to save one life. Now, I already alluded that I'm going to address the younger women, but before I do that, let's see what the New York Times has to say about screening younger women. Panel urges mammograms at 50, not 40. Well, as Dr. Bergen mentioned, this was prompted by the USPSTF recommendations in 2009. Now, I'm not going to read to you the recommendations verbatim, but let me assure you, they were much more nuanced than urging mammograms at 50, not 40. So how can I convince you that women in this age group need screening too? Well, let me go back to the meta-analyses, and let's look a little bit closer. You can see the USPSTF specifically looked at this age group, and they found a mortality reduction of 15%. And I already told you the Nordic Cochrane review, they focused on women in this age group. They amazingly got the same number. But let's go to the randomized controlled trial data. And again, amazingly, overall 0.85, which translates to a mortality reduction of 15%. So it's not quite as good as the 20% I quoted you, but it's still good. But there's a reason why this age group is going to remain controversial, and it goes back to that pesky number needed to screen. The number needed to screen in this age group is much higher. It's closer to 1,300. So that's why this will remain controversial, but in my mind, and this is just me editorializing, you know, if we're going to cut costs, which we're going to have to in healthcare, do we really want to cut costs, you know, screening young women in the prime of their life who are supporting families? To me, that just doesn't make any sense, but that's just me. So that ends the first part of my talk. Hopefully I've convinced you that there's a lot of data out there to support screening mammography. So let me go on to the second part of my talk. Good, not great. So a number of years ago, a good friend of mine, his mom was diagnosed with breast cancer. And he knew I was going, this was after I'd made the decision to go in breast imaging, and he knew I was somewhat familiar with, you know, breast cancer management, and we were talking about it. And at some point it came out that he was quite disgusted because he felt like mammograms had missed his mom's breast cancer. And it's true that she had just gotten a mammogram several months before she felt the lump. So it's quite possible that mammograms did miss her breast cancer. And it got me thinking, like, you know, randomized controlled trial data is one thing, but you know, you could argue that these are maybe ideal circumstances where you have people who are really well trained and really know what they're doing, but when you try to apply it to the real world with people of variable levels of training, maybe mammography just doesn't perform that well. Well, I'm not the only one to sort of think about this question. Back in 2006, this was published in Radiology, where what a group of very smart people thought to do was, let's survey real-world breast imaging practices and see how they're doing. And they collected a huge amount of data. It was like, you know, over almost 200 mammogram facilities, over 800 radiologists, and about 2.5 million screening mammograms. So they collected all of this data and they came up with benchmarks. And this is straight out of the BI-RADS manual. And this is actually one of the things I think is so cool about breast imaging, is we actually have benchmarks to which we can measure ourselves, and we're supposed to every year. So how am I actually doing? I think getting that kind of feedback in radiology is unfortunately pretty rare. But let's look a little bit closer at what our benchmarks are. So our cancer detection rate per 1,000 exams has to be greater than or equal to 2.5. Our recall rate should be somewhere between 5 and 12%. Our positive predictive value 1, which is our positive predictive value for screening callbacks, should be somewhere between 3 and 8%. That means 3 to 8% of the time when I call a woman back, she should have cancer. Our positive predictive value 2 is the positive predictive value for biopsy, which is between 20 and 40%. So that means between 20 to 40% of the biopsies I perform should yield cancer. And then if you can measure your sensitivity and specificity, they should be greater than or equal to 75% or between 88 and 95%. And the rate limiting step here is your false negatives. Do you have a good way to capture your false negatives? And if you're enrolled in a tumor registry, it's actually pretty easy to do. So what I think is very cool, and this is actually just published this month in Radiology, is someone had the brilliant idea to ask, well, okay, 10 years ago we set these benchmarks. Are we actually meeting them? And so just this month, they published an update to the BCSC data set. So let's look, are we actually meeting our benchmarks? Well, our cancer detection rate is 5.1 per thousand. This is well above the 2.5 it needs to be, and in fact, it's higher than it's ever been. So we're catching more cancers than we ever have before. And to put this number in perspective, the overall cancer rate in this study was 5.9. So we're actually missing less than 1 cancer per 1,000 women, which I think is fantastic. Our sensitivity is 87%, which is great. Remember, we just need to be above 75%. And our specificity is 89%. And remember, the lower limit of the range was 88%, so we're within the acceptable range. Our positive predictive value for screening is 4%, which is great. Remember, we need to be between 3 and 8. And our positive predictive value for biopsy is 26%. Again, that's within the 20 to 40% range. So that's all good. But there's one area where there is room for improvement for a lot of us. And it's summarized really nicely in this table. On the bottom we have recall rates. On the y-axis we have number of radiologists. And in that gray box we have the number of radiologists within the acceptable range of recall rates, between 5 and 12%. So if you add up all the radiologists in that gray box, it averages that 60% of radiologists are meeting the benchmark for recall rates. But of course, the flip side of that is 40% of us are not meeting that benchmark. And it's very clear to see where we fall. 40% of us have recall rates that are too high. And that's where we need to, if we're going to make improvements, that's where we need to improve, is we need to decrease our recall rates. And the paper actually had a pretty elegant way to do this. They said, identify someone in your group who is meeting all the benchmarks. So not only do they have acceptable recall rates, but they also have good cancer detection rates. And then that person can be designated to double read all of the callbacks from radiologists whose recall rates are too high. And that shouldn't be too onerous, it shouldn't amount to that many studies, and it can give the kind of feedback that might be necessary for someone to lower their recall rates. So that concludes the second part of my talk, good, not great. So hopefully I convinced you that, randomized controlled trial data is one thing, but when you survey radiologists out in the real world, we're doing a pretty good job. So now let me go to the third part of my talk, and I will go over this very quickly, tomosynthesis. But as you know, I do like to show New York Times headlines. So 3D mammography test appears to improve breast cancer detection rate. So this isn't exactly a ringing endorsement, but it's about as good as we're going to get from the New York Times. And as you've already heard today, there's reason to be excited. There have been a lot of trials already involving screening mammography, and that's really the point I want to drive home. We've gone over this a lot already, but I just want you to see that these are large studies, these are multi-center, these are prospective, so it's good quality data, and we've got a lot of it, despite it being a relatively new technology. As we've already mentioned, we see more cancers with tomosynthesis. You know, the Oslo trial came out in 2013, and we saw our numbers go from 6.1 to 8. And then the STORM trial came out, it did even a little bit better. Then JAMA came out, and they weren't quite as good, but they still saw more cancers, okay? And then STORM 2 trial came out, and again, got similar findings to the first two. So I'm pretty convinced, I think there's a lot of data to support that tomosynthesis finds more cancers. And as we've already said, amazingly, most of these cancers are invasive. So as Dr. Bergen said, it's not like we're finding a bunch of DCIS. And as Dr. Sullivan mentioned, we're finding additional cancers in women of all ages and all breast densities. So when people ask me, who do you recommend tomosynthesis for, I recommend it to everyone. Decreased recall rates mostly. I am cautiously optimistic that tomosynthesis will decrease recall rates, but I'm not 100% convinced, and here's why. So when Oslo came out, they saw their recall rates drop by 15%. And so everyone got really excited because not only, you know, was tomosynthesis increasing the sensitivity, but now we're increasing the specificity. And it's pretty rare for any tool to do both. But then JAMA came out, and they didn't see their recall rates drop nearly as much. And then the STORM 2 trial came out, and they actually saw their recall rates increase a little bit. And you know, the BCSC talked about this in their update as well. And they said, you know, for many of our mammogram facilities, tomosynthesis did in fact decrease recall rates. But for a lot of others, they actually saw the recall rates increase. So I don't know, I think this remains unanswered. But I'm hoping as we get used to the technology, it will in fact decrease our recall rates. Now the ASTOUND trial stands out for a number of reasons from the others. One of the main reasons is because it didn't compare 2D versus tomosynthesis, it compared tomosynthesis versus whole breast screening ultrasound. But you could still look at the tomosynthesis data, and what they found is their increased cancer detection rate was like 4 per 1,000. So that's better than we've ever seen, and that's almost double what we're doing now. So that's fantastic. And their recall rates were really low. So this is encouraging. I think this supports that tomosynthesis increases sensitivity and specificity. But as an aside, what's really remarkable about this study is, you know, as good as tomosynthesis performed in this study, what was actually, I think actually most remarkable is that screening ultrasound did even better. Screening ultrasound actually found more cancers than tomosynthesis and had very low recall rates. So I don't know, I've always been skeptical of screening ultrasound, but the more I read and the more I talk to people, there may be some promise there. But you know, that's outside of the scope of this talk. You know, Dr. Sullivan mentioned this. I'll go over it very briefly. You know, the FDA approved synthetic 2D images, but do you have the literature to support you in that transition? Because more and more groups are, and I would say within southeastern Wisconsin, it feels like most groups have made the switch to synthetic 2D. And the Oslo trial found cancer detection rates very similar between the two, and the STORM 2 trial found the exact same thing. Fair amount of data to support the use of synthetic 2D. Now, are we calling a lot of stuff back on these synthetic images? That's a very good question. The Oslo trial said no, there was not increased false positives with synthetic, and the STORM 2 trial found exactly the same thing. So if you've made the switch to synthetic 2D, you have the literature to support you. So that ends the third part of my talk, and hopefully I've convinced you, as the other presenters did, that tomosynthesis really is a good new technology, and we have a lot of data to support it. So let me go on to the last part of my talk, called critical scrutiny. I'm going to end with another New York Times headline. Ignoring the science on mammograms. Here's a quote from the article. For years now, doctors like myself have known that screening mammography doesn't save lives, or else saves so few lives that the harms outweigh the benefits. This article really bothers me for a couple of important reasons. First of all, this is clearly an editorial piece, an op-ed piece when you read it, but it was not listed in the op-ed section. It was posted in the health and science section just like any other news article. I don't know who Dr. David Newman is. I will tell you in the article, you learn he's an ER physician in New York City. What his credentials are to really talk on this topic are never explained, and I still don't know what they are to this day. This headline was prompted by an article you've already seen. Dr. Bergen put in hers. This was published in the New England Journal of Medicine article. And to review the findings of this paper, there were two. One, that screening mammograms don't save lives, and that a third of breast cancers are overdiagnosed. But the reason I bring this up is not to talk about overdiagnosis, that Dr. Bergen did a great job. But for me, this was really eye-opening, because the further I dug into this paper, the more it became clear to me that very smart people could poke serious holes into the arguments which Dr. Bergen mentioned. And in fact, someone that I respect, and a lot of people respect, had this to say about the New England Journal of Medicine article. The New England Journal of Medicine article suggesting overdiagnosis from mammography screening is scientifically incorrect and should be withdrawn. I had never seen anything like this. I mean, and to me, I was very trusting. You know, if something's in the New England Journal of Medicine, who am I to argue? It's got to be right, until I read this article in The Economist, How Science Goes Wrong. And I really recommend y'all to read this article. It's really good, and it's free online, and you can read the whole thing. But it talks about some major problems that occur in scientific research these days, and they're very widespread. It highlighted 4 really big problems we have to deal with. The first is that negative results are much less likely to be published. And intuitively, there's no reason that should be the case, because knowing what is false is just as important as knowing what is true. Another big problem is that studies can't be replicated. There is a very scary study published in Nature where someone tried to replicate 53 landmark studies in cancer research. They were able to replicate 6 of them. That's really scary, because we base everything on the assumption that these studies can be replicated. Another big problem is, science is getting increasingly competitive, and good journals have very high rejection rates, and they're much more likely to publish striking findings. So this just encourages researchers to cherry pick their data and exaggerate their results. This stuff happens all the time. The final big problem with research is in the peer review process. The Economist article talks about a now famous study in BMJ where the editor of BMJ created a bogus study and inserted 8 major flaws into the paper and sent the study out to all over 200 of its reviewers. On average, the reviewers found less than 2 out of the 8 major mistakes, and no reviewer found all of them. So that's why this was an important lesson for me, and the lesson I think is summarized nicely in this quote by Dr. Smith. There is a need for editors and peer reviewers to subject skeptical views on mammography to the same critical scrutiny as favorable findings. And that's the term I really like, critical scrutiny. The lesson for me was I need to do my own critical scrutiny anytime I read anything that's published. And I think personally the best way to do that is to rely on a preponderance of data. What are the trends? What are multiple studies showing? Are they finding the same result or a different result? And hopefully in this talk, I've done that. I've shown you that, not just what one outlier study showed with a striking finding, I've showed you the trends. And I think in particular, we need to be skeptical about how the media interprets these studies. Because let's think about it. The people reporting on this stuff, for the most part, are not scientists, and they're not physicians. They're journalists. And at the end of the day, a newspaper exists to sell newspapers. And the more striking finding, the better, regardless of whether it's true or not. And a nuanced discussion, well, there's just no room for that. So anyway, enough of my soapbox. That actually concludes my talk. Hopefully I've taught you the takeaway points are screening mammograms saves lives. So if you screen women regularly, you reduce their risk of dying of breast cancer by 20%, and you only need to screen about 200 women to see that benefit. Ages 40 to 49, it's a little bit different. The survival benefit is 15%, but you need to screen a whole lot more women to do that. So thank you.